First, I would like to thank, of course, Waters and Prognosis, John and Mark, for giving me the opportunity to come in and share a little bit of the research that we've been doing in the area of prostate cancer, specifically in the recurrence. I do manage a course, so I'm going to try to keep a lot of the things more high level, but at any time, if you have questions more specific, come find me. Be more than happy to discuss some of the details more in depth. I also will have a poster later on today, not on prostate cancer, it's actually on exercise physiology. That'll be in the lipid section. In terms of this particular project, was kind of a progression in our lab that started probably more than 5 years ago, where we first wanted to just simply try to detect prostate cancer a little bit better than the average PSA. And of course, the PSA test is one of the gold standards. It's one of those things that it works fairly well and people are pretty happy with it, that it has some problems, but really that's not where a lot of research is placed. And it was really more of a question of recurrence. And we got a collaborator that had some really great samples, and what we were trying to determine is, can we try to help predict recurrence? So a lot of you have already seen a lot of the prostate cancer stats before. Just like prostate with a lot of other cancers, they all kind of have the same MO, in that if we can detect it early, we have a really good chance of managing the disease, whether or not we can completely cure it or at least extend life numbers of years. Prostate cancer is no different. If you can catch it before it metastasizes, treatment is very highly successful. But with that being said, it was interesting from the clinician point of view that when they would go and perform and do the surgeries, regardless of where the initial stats were for a particular patient, they couldn't predict how well the surgical intervention would go. It didn't follow the same trends, and that is what kind of led us to what we're going to talk about today. Again, for the gold standard in prostate cancer treatment for a patient who gets that unfortunate diagnosis, they're going to have really one big choice, and it's usually between surgery and radiotherapy. And what's kind of interesting is there's really nothing out there to help guide that decision. The physician, they have their own knowledge base, but really that's not something that, they can share that with the patient, but there's no studies to say, oh, well, surgical is going to be a lot better for you or not. Now, granted, there's a few other therapies like cryotherapy, hormone therapy, chemotherapy, immunotherapy, and the last is just where you watch and wait. But really, to make that first big choice, there is no information out there for that patient. They will have maybe their PSA value, they'll have a clinical biopsy, most likely, and then they have to make that big decision. And unfortunately, those patients are making the decision based on more lifestyle. There's a lot more patients that are willing to go in, say, I want to cut out, I'll go have a one-time surgical intervention and I'll be done with this. Or they're fearful of surgery for whatever reason, they'll go the radiotherapy route where they'll have to go through a series of treatments. It takes a lot longer, but again, each person's different and they'll choose it not based on success or potential success for the therapy, but for reasons that aren't quite related. Now, when we talk about recurrence, the term that comes up is biochemical recurrence, because how it is determined once you have surgery is you keep monitoring the PSA value, and when that PSA value goes up to above 0.2 nanograms per mil is when you are officially in recurrence. So this is just kind of to show a graph of one particular patient that I pulled out of a case study, where following surgery, it was more than a couple years, and then all of a sudden their PSA started to rise, and you kind of see it bumps around a little bit until it finally hits above the mark of 0.2, and then intervention had to take place. Now, unfortunately for these patients, prognosis at this point is fairly dim because they've already exhausted some of the very basic means in which to tackle the disease, and they have to go with other strategies that are a little bit more not as successful. So what do we have, and what has been tried out there in terms of available clinical data, and pretty much that's what all of these are dealing with for the most part, is what is available to the patient to try to predict their risk of reoccurrence. The PSA value by itself, of course, is not sufficient. They've tried to put in the Gleason grade from the biopsy that had monitored success. The second one, the PSA velocity, is actually one that I find very intriguing, not necessarily just because it focuses on PSA, but more so that it's looking at something that it's changing. They're looking at how the PSA value changed in the year before the treatment. And they came out to be something about 2 nanograms per mil per year. If the rate of that was greater than that, then the likelihood for a poor outcome was increased. So I really like the fact that there's so many of our metabolomic studies that we focus in on static sampling. And it's always hard because we're not in total control of what we get from the clinicians, but having longitudinal study or samples from one patient is so powerful. And being able to look at trends and how those trends reflect what is going to happen later, I think, is extremely powerful. And that's where I think most of our metabolomic studies are going to be going in the future. As soon as we can get the money to get those a lot more expensive, and not as many patients want to always agree to having that many samples taken from them, but that is where we really need to go to really make a bigger impact into medicine. Some of the other ones, again, we can look at RNA expression, the PSA isoform, histone modifications, a very exquisite compilation of a whole bunch of different metrics like the kappa or the nanograms, but all of these have only had marginal success. And so that brings us to our particular cohort. Again, these were patients that were collected here locally at Emory University. We had 40 or actually it was 80 total cancer patients, and these were patients that we got samples before surgery. So they would come in, we would get their serum before surgery, and that's what we analyzed. Oops, sorry. And then they were followed up for a minimum of at least 3 months, and then they were able to be put into recurrence or remission groups. Now, of course, with this active model, and we did experience this, is kind of frustrating, but it is what it is. As we go along, we find out that some people that were in the remission bucket did recur, so we had to go back at some point and redo the analysis. And that's part of what we have to deal with, especially in active patients. As you can kind of see, we have what is called the preoperative clinical TMG. This is a staging based on just the biopsy. So you kind of notice that there's a distinct absence of any type of metastasis. So you have just stage 1 and stage 2, and that's because, when you biopsy the prostate, which is not a pleasant procedure in any means, you don't have the ability to take also lymph nodes. So you don't know if it's metastasized. So really you only know whether or not it has just barely gone, or what's the location within the prostate for the most part. And then, but from there, you can get a Gleason score, and a lot of people have looked at and tried to use just the Gleason score to try to determine and predict outcome. Now, from this particular subset, I just wanted to show that, based on the information that we had a negative predictive value of about 88% and a positive predictive value of 67%. So it wasn't great. I definitely would love to have a lot better statistics on it before I was going to make a decision along those lines. What may be a little bit harder is to see on the bottom of the slide is kind of one of the, another paper kind of published that would say really the high risk people would be with a PSA level above 20. Okay. Granted, what I wanted to show you in the graphs here is the age distribution. One of the things, of course, anybody in metabolomics, that's one of the biggest things that we always want to make sure we do an age match, but we try to match as many things as possible. Unfortunately, it depends on who you work with and what metadata you get from the clinicians. As much as we can get, we try to match, but usually it's very sparse until we get further into the study. And then I also showed just the range of the PSA values, and you can kind of see the PSA values in this particular cohort. There was very few that had PSA values above 10, and really there were only 2 that had above 20, and both of those, the one that had the highest, it was a 37, and that actually until it was like 35 months until recurrence. Now they did recur, but they didn't recur extremely fast. And the one that was just above 20, well, that was about a month. So obviously there's more going on in just that risk level, but that's probably pretty good in terms of maybe stratifying those, but there's so many other patients that wouldn't be able to benefit. Now, in terms of projects as we've gone through Facundo's lab, this is probably the one that we were most ambitious with in terms of the amount of coverage that we underwent. Just like the last speaker, we did helic and reverse phase, so that was kind of easy. That's in our wheelhouse, but the particular student, which I forgot to mention at the very beginning, Shavian, she had a lot of NMR experience, so that was really nice that we were able to bring that in, and she was able to collect the NMR. And we were able to, for the first time in our lab, try to merge these two data sets of NMR and mass spec and try to make them work well together. Because again, everybody who does mass spec, we kind of look at NMR and go, yeah, you kind of do okay, but mass spec is where it's at. We can see so many more things than you can. So the polar, for the most part, that's what got split. It was just a simple, we take the serum, we mix it with methanol, precipitate the proteins, and then that sample got split. It got split to be able to do NMR, but also it got split to do the helic runs. And then we found that over kind of a trial and error for a good number of projects that, and also for simplicity's sake, we try to keep the lipids to a one-phase type mixture. We don't do a two-phase. The one phase is just with isopropanol, and we can do it just like the methanol. We add it in a ratio 3:1, and we can run those on the reverse phase. Now from there, the rest of the metabolic workflow is very similar to what everybody's used to. We got to separate it and analyze the peaks. Then we have to do some data processing, and that's where prognosis comes in to be able to pull out all the data that is important and be able to put that into a useful fashion so that we eventually can put this onto pathways and try to then work with our clinicians to really start creating stories, start looking at hypotheses, and really making science and personal medicine drive forward. The data was collected. At the time, we do have both a couple different synapses in our lab, but this was, at the time of this project, we had just recently got a thermo orbitrap. So of course, this particular student was very excited, and they pushed to have everything run on that, which was perfectly fine. Again, some of the details in terms of some of the mobile phases, pretty straightforward in terms of the reverse phase. A lot of lipid people do use the IPA acetonitrile with formic acid and ammonium formate. It's pretty standard. In terms of the helic, we did it was a X-bridge BEH Waters column, and that was, at the time, I was very pleased that we were able to find a basic protocol that was very stable. For the long time before that, getting helic data was a major challenge for us. But once I found the basic method, that actually worked very, very well. It was very, very stable. It actually turns out that basic method, unfortunately for the ultimate that we were running it on, was compatible. We've since gotten a Vanquish, and when you get to the Vanquish, the basicity tears up the pump seals, and basically I'm asking for a PM right after I do a study. So we had to move to a more acidic one since then. And again, the acidic one is almost just as stable. A lot of overlap between the two, but both methods have been very nice for us. These were collected on a Q Exactive HF, both positive and negative modes. We collected at the highest resolution, and of course, with all of this data, we have tons of data sets. On the NMR side, the data was collected on a 600 megahertz Bruker Advance with a 5mm cryoprobe. The experiments were a NOSI, one-dimensional NOSI, and that generated most of the data. And then the HSQC and the TOXI are the ones that are used on a pooled sample to help in annotation of that data. Very often, it's hard in some of these talks to be able to show too much of our raw data, but in this particular case, we were very pleased because even at the highest level in a TIC, and hopefully you guys can see it, there was actually major differences that are easy to see, and this usually never happens in any metabolomic experiment. So the fact that we can see this already was very, very pleasing and very unexpected. Again, what you're seeing is the positive and the negative from the helix, positive and negative from the reverse phase in the NMR. What you may not be able to see is that the recurrence is in red, and then the ones that are in remission were in blue. So the big red peaks that have dominated over the blue ones are the ones that there must be some combination of signals in there that is going to be something that we want to look at. Again, we did use Prognosis QI. We actually do have multiple platforms. We do use probably on the kind of waned over the years, but MZ-Mine as well as Compound Discover. But Prognosis in this case, she did try all three, and Prognosis for this case won out. She was a lot more happy with a lot of the QCs and quality control things that we do put in place. Some of those, I didn't have a slide on them, but one of the things we do in terms of experimental is we do make a pooled sample of all the samples and run that as a QC, and that gets run at intervals probably of 10 to 15 samples. Even though it wasn't for this particular study, but we have incorporated in more recent studies, is we do also now include radio-labeled internal standards. And all of these have all been extremely valuable measures to help us improve our analytical data capture. Even though I always kind of hate to put these types of figures up, but this is what a lot of people want to see, especially clinicians. They want to know that you ran something, you're spending a lot of money, and I found a lot of stuff. Even though the 72,000 features is really, okay, yeah, we know what all that really means. Well, the number that's really the more important number is the 1,700, the one that after filtration, the one that is the significant things. And the fact that we have almost 2,000 features, again, is a phenomenal achievement in this particular, but maybe not as expected, just for the sheer fact that we had so many differences in the TIC. One thing to note, if you're not familiar with NMR data, that those points are not necessarily peaks, they're data points. So there's a process when you process the NMR data, it's put into bins, and it's those bins that are data points that show significance. So it's not actual peaks like in mass spec, but it's a little bit different. Then comes the fun work. Once we had that 1,000 things for this particular postdoc, it wasn't immediately tied to graduation, so we could push her a little bit more to identify a little bit more stuff. But if it was a graduate student doing this type of project, asking a person to do 1,000 things, that would be almost impossible. They'd just look at us and go, well, I'm never going to graduate, and that's probably the case. For anybody who's been doing metabolomics for a while, that was definitely the case about 5 years ago or so, but the tools that we have now are so much better than what we've had before. The fact that I can sit down and annotate 10 to 20 things within a couple hours is amazing. The tools that we have, the ability to work with and pull out this information is phenomenal. But really, the art of feature selection is something that I think will plague us for a while, because there is not a single way that we have to go through and do everything. And I always hated that answer at the very beginning. I can't tell you exactly what to do. It's all depending on your data set. But over time, that's exactly true. Depending on what your data set looks like is what you're going to employ and how you're going to move forward. But really the biggest goal of feature selection is it's a data minimization. We have to go down from 1,000 some things down to something that is more manageable for the current situation. So in this particular case, we use genetic algorithms. We have employed a lot of different feature selections over the years. Genetic algorithm just tends to be a little bit more across the board, applicable to a lot of different situations. So I like applying that first and then looking after that. In terms of why this is a little bit different than just applying the genetic algorithm is once we get it nested down, the genetic algorithm does tend to put in a little bit of redundancy into the data sets. So we did use a reverse IPLS DA to further refine that data down. And what that would look like is, so if I got down to with the genetic algorithm down to say like 30 or 29 features, I would start the reverse IPLSDA. So basically it would take one of those features away, and it would test them all and see which one wasn't necessary. And basically what I'm showing you in the plot is I've taken one away all the way down to nearly 0, down to 5. And this is exactly what you would normally want to see for any type of data set, is that the scores, and the scores that I'm representing here are the accuracy, sensitivity, and specificity, in a cross-validated fashion, are going to keep rising to a certain point, and they're going to drop off as soon as you have taken away all the important information, and the model will fail. And what we're trying to do is, again, minimize what we have to go after, and it depends on really the end goal of the diagnostic. Depending on who you talk to, it may not be a mass spec diagnostic at the end. It may be another type of assay, which then, of course, anytime that you have over maybe 20 analytes, people are going to start to shudder and go, oh, there's no way we're going to ever be able to implement this. But I have hope that as more studies are brought out, that limitation is going to be just going to go away, is because we can do this with mass spec, and mass spec can be in the clinic, and they can do these types of profiles. But what was nice is we were able to get this down to 14 metabolites, and we had really good separation in OPLSDA. We were very pleased, but of course then the next part is you go back and try to identify things. And usually what I think I tell all the students as a rule of thumb is you're going to be doing really good if you identify half of these. Because a lot of the times, even though all the software packages do a really good job of getting all these tentative IDs, for whatever reason, the ones that are most interesting and the most unique are the ones that are a little bit lower level, which usually you don't get an MS2 for, and therefore you don't really get a great identification hit. So yeah, those are the ones that are more challenging. They just apparently seem to always be the ones that are more interesting. So in terms of the metabolic identification or annotation, really most of this is annotation. Identification should be really reserved for when we do have standards. We definitely use the accurate mass, use the isotope ratio, matching, and fine structure. The tandem MS2 is by far, I believe, is the currency of what we should use to start talking about structures and matching and really identifying things moving forward and annotating things moving forward. But of course, the retention time match, I put variable here is just because if you use different systems or different labs, that is not always the most useful, whether or not you go to a retention time index. There's a lot of space in that arena to really keep pushing forward and trying to get something that is more universal across the board. On the NMR side, that's where they do an LC SPE for the deep annotation. But then what we wanted to find a better way to correlate the mass spec and the NMR data, and that's where we came up with the statistical heterospectroscopy. This is probably going to be a very busy slide, I apologize, but for the most part, we start off with a feature table of things that you don't know. And maybe we'll focus in on the red, the A group, where there were 3 potential candidates. We had MS information for all of them. Each of them had multiple candidates as potentials. But one of them, for inosine, we had the NMR. And the NMRs is very, very powerful in the fact that when it does find it, we know with pretty certainty that that is the right compound. A little bit different from the mass spec side, and they can get quantitation. But once we knew that and we could kind of anchor things around the inosine, then once we build a correlation table, and this, I think most of these were Pearson correlations, then we kind of walked through, and A was highly correlated to C, E, and G. Now, based off of that and knowing a little bit about the pathway, that was helpful to correctly identify those other 3 metabolites of hypoxyxanthine, xanthine, and another one that I can't quite read. And so from there, we can either use the knowledge of the pathway to help go and find things, or kind of revisit the data again. And there could be other groups, such as the B, D, F, and H, where we have NMR data or we may have mass spec data. Again, we may have multiple candidates, but we can use the pathway to help drive which one of those are most likely the case. And then the nice thing is once you kind of help narrow that all down, it's a lot easier for somebody to go through and help verify whether or not be through with standards and everything else, because of course you'd be looking at, just for this very simple example, several standards you'd have to buy as opposed to being even more confident and using your money a little bit more
Sponsored by Goya. If it's Goya, it has to be
so
good.
Of course, one of the things I know I mentioned before that it was a panel of 14 and now it kind of jumped to a panel of 20. And that was simply because, well, once we got down to the 14 and the success rate of finding the identities was not as great as we had hoped, she took a little bit different strategy. And instead of putting all the data in and hoping that the best stuff would come out, she started off with just the significantly different things. And that just led us to a slightly different panel. There was a lot of overlap, but a slightly different panel of 20 metabolites. And these, well, I'll talk about a little bit more, but there's a combination of lipids as well as some of the compounds that I've already mentioned. One of the struggles with any of the metabolomic type papers and things is the confidence levels. There's a lot of different things that we choose out there. This particular one is probably, I wouldn't say would be my favorite, but it was what we had at the time, which is just a 5 level based on the information that we had. So the lowest was we just had an annotation based on accurate mass. That was a level 5. And the top one was where we matched it to an authentic compound, such as a standard. One of the things that, of course, we want to kind of just check with our models is, well, in the first line, we wanted to just use the clinical markers only, try to build the model with the data that we had, and we had very marginal success in terms of the accuracy, sensitivity, specificity of 64%, 84, and 45. So again, that's just reaffirming that our clinical markers are not the best at this particular data set. But once we put in our panel of 20, the scores were up to 92, 94, and 91. And then, of course, we always want to check just to see if we add those clinical markers in, do we get a boost? And really, for the most part, it's about the same. So the model, at least that we had built, was indifferent of whether or not we included those markers. And I know this is a really, really busy slide, but I just wanted to kind of just give you a quick look at what some of the Pearson correlations and how much rich data is in here. We highlighted 2 pathways, a purine pathway and a TCA pathway. Couple of the things that, especially when we start to go present this back to the clinicians, having some of this pathway type information is probably one of the more valuable ways to start the dialogue, because they immediately go to whatever they're hot and their desires to move things forward. And one of the things that was very interesting was the simple fact that when they looked through all of the data that we had, and there was a lot to look through, but they kind of just focused very quickly on something that was very simple to us. I mean, the simple things, they're never exquisite, so we never focus on too much. But they like the glucose and lactate ratios, because they're like, oh, if we can really build a model off of just those, that would be great. That's something already clinically collected, and we can just use that. Now, of course, it's not going to be quite that simple, but at least they were able to grab onto something and talk about things. Of course, this slide is very small for you guys to see, but for the most part, most everything in these pathways was upregulated in the recurrence. One of the ones that I'll just point out is serine. It's it's hard to see, but there's a slight difference, an increase in the recurrence over the remission. And I'll talk about that in part of the next slide, which is we did collect a lot of lipid data, and one of the things I charged the student with was I wanted a better way to be able to kind of share with everybody the overall trend or trends within the lipid classes. So she came up with a couple different plots, which I kind of like. One, and this is just simply the number of lipids that were identified by MS, and then kind of the ratio of what was elevated. And for the most part, most of the lipids were elevated, and these would be more like the free lipids in the plasma at the time of right before surgery. So there was an environment thing here, and that's one of the things that I think in terms of cancer, it's that environment of what is happening at that time is very valuable to understand, not necessarily other attributes. Now, the one thing that I wanted to point out was the one that's in blue, which was an increase in the remission. These are glycerol ceramide class. I don't fully have a mechanism to fully explain this. I know that they are been indicated in drug resistance, that they have an effect to reduce the ceramide levels within the cells to help increase the longevity of some of the cancer cell lines. How that really affects us in this realm, I'm not really entirely sure. But the other things we looked at was just basically the fatty acid chain length to see if there was a major shift or anything along those lines. And that's kind of the stuff where we're keep moving forward on. So really just in conclusion, we were able to look at about 1,700 significantly altered features. And the nice thing, again, these are predictions in serum of patients before anything ever happened. So this is really probably one of the more exciting metabolomic studies from my perspective that we've conducted so far, just because it does mean so much to the end patient. If we could find something that would give them better information to how they could change or make a more informed decision moving forward based on basically a simple blood test. We did see that there were systemic and significant changes in the metabolome between those two groups. And we're really at the point where we have a potential of several panels. And the next step is to get, we only have 80 patients. The next step is really to get more patients and validate the results and try to narrow it down to what are the most useful metabolites in all of that, the data sets. Again, I just want to thank the Shavian, who did most of all of the work in terms of data collection and processing. Facundo is the fearless leader. John and Rebecca, they're responsible for the samples. And then Art was instrumental in helping us collect the NMR data. And then finally, I just point out that we do have a core services at Georgia Tech.